not only because the sheer number, but also the technology has made it possible that all the patients are going to live longer and longer. So all these, not many patients will die, some will die from it, unfortunately. But so they would need constant care, investigations, management, change in strategies, all that would create a huge health burden. What are the risk factors of prostate cancer? One is age. As we growing older, above 70, they say, I quoted the number 1 in 9 will suffer from prostate cancer in their lifetime, but it will also almost be 1 in 4 people after age 70 who would have some focus of prostate cancer. They might not be aware of it, they might not die from it, they might have other problems that the health would succumb to, but 1 in 4 would have some sort of prostate cancer focus in them. Ethnicity. Certain ethnic groups have larger propensity of having prostate cancer diagnosis, especially men of African Caribbean descent. Family history is very important. People with first-degree relatives, for 1 or more who have been diagnosed in earlier age group with prostate cancer, would have greater chance of getting prostate cancer. And then other risk factors, obesity, taking hormone therapy, alcohol, all that has some part to play, as in many other cancers. So what are the stages of cancer? When we look at cancer in general, we stage them from 1 to 4. In prostate cancer, it's a little bit different. We are not so much worried about stage 1 to 4. It's more how much the prostate gland is involved in the cancer, which is the localized disease, locally advanced when it has breached the capsule of the prostate and started to come outside into the tissues around it, seminal vesicles, bowel, bladder, those, or advanced metastatic disease when it has gone through the lymphatic and blood flow and gone into the bones and other parts of the body. So these are the main. Localized prostate cancer. Then we divide them further, very low risk to intermediate risk, locally advanced, which could be a T3, T4 disease, different mechanism of attack on this cancer, and advanced metastatic prostate cancer, which possibly we can't cure it, but we can control still for longer period of time. So the first 2, localized and locally advanced prostate cancer, they're all still very curable. Advanced metastatic prostate cancer, we can't cure it, but still people can live for many years. So cure is not possible, but control is still possible because of newer drugs, newer mode of treatments, technology, all that would make it possible still for people to live many years. So what is the percentage of prostate cancer relative to other cancers? So 20% of all other, if 100% of the cancers, we have 100 number, that is for all cancers, including lung, breast, gynecological. Prostate cancer would be 20% of the burden. So 1/5 of the people coming into the cancer center will be diagnosed, will have a diagnosis of prostate cancer. So 20%, that's a large chunk of our service. So many of us are practicing treating the prostate cancer just because of the sheer number. And one of this statistic, don't get bogged down with this, is currently that 11 patients will die from prostate cancer, but those are not new diagnoses. Those every day 11 would die, but that doesn't mean they are newly diagnosed cancer. They might have been under treatment for 10 years, 15 years, 7 years, whatever. And every year, every day, that's roughly the number. So what is the percentage of people diagnosed with prostate cancer would die from it? This would be roughly 10%. So 90% still will not die from prostate cancer. They still can live for many years. Very good statistic. That's everybody should focus on. So what is the percentage of prostate cancer? So what we want to do in any cancer is we want to diagnose it early. Earlier we diagnose, the lesser the intensive treatment, more chances of cure, and lesser side effects. So localized cancer, when we find it in prostate cancer, it's about 77% of the cases. So that's wonderful news as well. When we diagnose prostate cancer, many of them are 77, and out of those 77%, one third could have no treatment. Like we have many patients that we just put on active surveillance, meaning we are just watching cancer from time to time, actively seeking that if they are getting aggressive disease, when and only treat when the disease becomes aggressive because of the potential side effects. And it's called surveillance. And surveillance has been proven in many countries, and we do that here in Canada as well. So I love this slide. So on the left side, you see the year range when we were treating from 1975 to almost now. You can see in 1975 to 77, when we did a consensus of what was the percentage of 5-year survival. It doesn't mean that they don't live beyond 5 years. 5 years is just a number for comparison we take in all cancers. So 5 years survival in prostate cancer was about 68% in 77, in 70s. In 80s, it increased to 83%, and 2009 to 2015, another consensus was taken, and it's almost 99% people, despite having including people with very aggressive and widespread disease at the beginning, they still could live for more than 5 years. So astounding statistics in that sense. So how did we come to this? What did we do to improve the cure rate or survival in prostate cancer? First, awareness. Awareness is so important. And what you guys are doing is exactly the thing that make people aware of the prostate cancer. You're not afraid to talk about it. You help each other knowing about it. You help look at the technology that is available and ask questions. So that awareness had made a tremendous change. Prostate cancer, breast and lung, we can't thank the patients enough how much input they have been into this. All that awareness, pressure to the government, writing letters, in collecting funds, talking to other patients. It's tremendous how much change you have brought about. And now what we were doing previously was we were treating as a box treatment. Everybody who would come in a prostate cancer, we had only a couple of drugs and couple of ways of treating it. In 70s and early 80s. We would treat everybody in the same way. Now we individualize prostate cancer. We talked about localized cancer, localized advanced cancer, metastatic disease, and within each group, then we have where we can change the outlook by looking at the cancer, how it's developing in that person, genetic makeup of the cancer, genetic makeup of the patient, and many other things that we look. So treatment has become quite individualized. In each of your case, there will be some. So give me 1 second. I have to just do something quickly. I'll be back in 1 second. I apologize for this. Check. I can give you a check or
Credit, cash credit or check, either way.
I apologize. We had some disaster in the house and some people are working in the background. I have to authorize something. I apologize. So we talked about increased awareness that has brought up a change. Treatment of each patient is individualized. Then availability of global data that has also had a big impact because previously what was happening was people were treating in England, people were treating in Scotland, Australia, Finland, and they had their own data. It was not collaborated. They didn't corroborate with each other so much. Now, by law from not government laws, but our own associations, we have to share all this data. So we share our anonymized data from Saskatchewan to people in Norway or Sweden or Britain so that we know what is working, what's not working, how we can tweak things. So that availability of global data, and that's one of the pressures of patient groups that has done that. For instance, in breast cancer, they do breast cancer um, conference every year in San Antonio. And that is brought about by patient advocacy group that make sure that all the people attending there bring their own data, and that has evolved the early breast cancer treatment quite a lot. It's called Early Breast Collaborative Trialist Group. Huge change. Then there's advancing technology, of course. We have tremendous change in how we diagnose, how we do biopsies, how we interpret biopsies, how we treat with radiotherapy, how we do surgeries, how we do hormone treatment. All that advanced technology, which we'll talk later as well, has changed the scenario quite a bit. Then creation of treatment guidelines. It's very good that we share, collaborate with each other, whatever. But do we make sure that everybody treats in the same way? Yes. So there are treatment guidelines, whether you are in Regina or in Nova Scotia or BC Cancer Agency, we tend to treat each group in the same way. We have Canadian Urological Association. You can look at their site and download some of their guidelines, make sure that you are being treated accordingly. So all these guidelines have also made a tremendous change. So advances in prostate cancer, what have we done to do this? So we used to do biopsy by transrectal ultrasound. I'm glad to tell you that we have brought transperineal biopsy now in Regina and Saskatchewan as well. So instead of putting a needle, which I will explain by diagram later, instead of going through the rectum, we can go through the perineum now, and it's less infective process and more accurate, and we can take multiple biopsies. And currently one urologist is doing it, but we are hoping that many other urologists and radiologists will follow suit and be trained on doing transperineal biopsies. Transperineal biopsies are also fused with MRI or ultrasound, which also, if we see a nodule there or if we see a specific site that needs to be addressed more thoroughly, we can do that currently. So that will also help us finding small amounts of cancer. We also have ARATs, which is androgen modulated treatments that were not available previously. They are also changing the landscape. Now they were being used as a third line treatment. Now we are using them with very aggressive cancers upfront and seems to be working well. Immune therapy, molecular therapy has come into it that again has changing quite a bit. PARP inhibitors in people who have a BRCA positive prostate cancer, we are using them as third and fourth line, and with time this will come up front treating in second or third line as well. Targeted radiotherapy via PSMA lutetium is a drug that can be tagged with the PSMA scan which can go specifically where the metastases are and treat locally. And I'll show you a fascinating diagram about it later. Any questions so far? Or should I continue?
Just one question back here,
Yeah.
Doctor, just a minute.
Can you please explain, Dr. Amjad, the BRCA1 and BRCA2? I know it's fairly recent information, and a fellow beside me is just asking about it. Can you explain it further, please?
So BRCA is a gene that we were using to identify certain families that the breast cancer runs into. But it turns out to be that you can see that gene in prostate cancer as well. And if you are positive with this, certain types of medication you could be qualified for. So it's not to test whether your family runs the prostate cancer, it's just to see certain drugs you qualify for. And it's only valid in people who have a positive BRCA gene.
Thank you, Doctor.
So this again shows risk factors, age, family history, hormones, race, other things. This is the diagram for prostate cancer. Can you see the arrow there on my screen? Yes, so this arrow shows, how the prostate cancer is really embedded within the surrounding tissues. Up front towards the skin is the bladder, back towards the bone, there is the bowel, then there is the sacral bone there, and then penile bulb down there. So it's very embedded within all these structures. So somehow we have to treat prostate cancer, and that's why you sometimes get these effects of inflammation in the bladder or bowel. You can appreciate that these structures are very close to it. And if you try to be very adventurous and don't treat part of, say, small sliver of bladder or bowel, you'll miss part of the prostate cancer treatment in radiotherapy. So looking at this diagram makes you appreciate that why this is important, or why there are some effects to bladder and bowel in radiotherapy. Same thing. So this is a new fascinating scan that is currently in the development. It will light up certain small cancers that will be available. This has been fused with an MRI, and we can appreciate where exactly it is. So what the aim is that we will do very targeted, we will do blind biopsies, but we will do excessive extra biopsies through this in this area. And then if we have to retreat at future state, or we can be brave and just treat locally this area and not treat the other prostate, but that's for future. Currently, we are treating the whole prostate, but this is where the technology and development and how advances are made is coming to fore. Again, the lower part shows how close everything is, and also you can appreciate these nerve endings that go into the prostate, and sometimes we get erectile dysfunction, urinary incontinence, bowel issues, all because of the nerve damage. There is a whole network of nerves that goes into the prostate, and once you operate or give radiotherapy, they get damaged and they get scarred, causing the symptoms. So this is an MRI. Many of you have seen these slides before. These are the MRI images that we take. MRI works through magnetic resonance, where north and south pole of the magnet from in that small tube go left to right and create images when they pass through certain structure. And we can orientate magnets in different ways to cause different types of imaging. So T2, T1, diffuse imaging, flare, all these are types of images that are very useful in prostate cancer. When we see a lesion, we want to see it more precisely in other kind of parametric MRIs. So it's called parametric MRI, meaning that we take multiple different types of images within the same time frame, and that gives enhanced imaging of where exactly the prostate is, where exactly the lesion in the prostate is. So this is a typical flow sheet. You guys would have gone through this as well, that you go to your family physician with either an elevated PSA, which was detected on routine physical examination, or you had what we call LUTS or LUTS, lower urinary tract symptoms, like frequency, urgency, and waking up more frequently at night, blood in urine, all that. So that the family physician does an elevated looks at the PSA, it turns out to be it is elevated, and each age group has a different number that we look at. So if your number from your age group is more than normal, then you do the next step, which is you do a digital rectal examination or physical examination. That leads to a biopsy. So biopsy, if it is negative, but the PSA is very high, we tend to repeat the biopsy or do further MRIs, do further examination, put on surveillance. However, if the biopsy is positive, then we have to see whether the disease is indolent or aggressive, meaning whether it's localized, whether it has spread. So what we do CT and bone scan and all that. If the disease is very indolent, it's very localized, it's very small, and it's very, very low risk, we can put people on active surveillance, which is here. If on the other hand, if it is very aggressive disease, then we go through surgery, radiation therapy. If it has spread beyond that, there's no point in treating locally, we should treat the whole body. Then we put them onto androgen deprivation therapy or hormonal treatment, chemotherapy, PARP inhibitors, all that come into fore. So how do you define low risk? Low risk disease is when the PSA is less than 10, Gleason score is 6. Gleason score is sign of how aggressive looking the cells are under the microscope in the biopsy. If the Gleason score is 6, PSA is less than 10, then people can live for many, many years with prostate cancer, and it will be only after many years that it will become aggressive. So you don't treat them. Majority of very low risk patients, we put them on active surveillance. If you have an intermediate risk cancer, which would be when the PSA will be between 10 and 20, Gleason score would be 7, or stage T2, which means it is palpable with the finger. Then you either can do surgery or radiotherapy, which we'll talk later. High risk, you still can do in certain cases surgery, but possibly more than likely you'll go through radiotherapy and hormonal treatment. Plus minus, we have started doing additional treatments already, which were not possible or not available even a couple of years ago. We have started, if somebody comes with a Gleason 9 or Gleason 10, very aggressive local disease, which has not spread, we will treat him with radiotherapy, hormonal treatment, and some localized treatment, which are called ARAT, which is modulation of the receptors in the cell membrane, stopping them to enter into the cell structure. So that is also changing the outlook for these high-risk cancer. And metastatic, we usually start with hormonal treatment and then option of chemotherapy and other drugs. So this is what I was talking about, the guidelines. So we have a lot of nomograms that we follow. I don't treat them based on my hunch or my experience. I treat them what is evidence-based medicine, meaning I categorize them first. On the left side, you can see very low, low risk, intermediate, high, and very high risk. Then I look at their pathological features. Then we do imaging and look at them. Then in some cases, we also do germline testing or molecular testing. And then we present them in tumor board. And we have 2 rounds where we discuss prostate cancer. On a Tuesday, we discuss all new cases, and make sure everybody is in the same page. And it is attended by medical oncologists, radiation oncologists, all of them together, and we sign off which category this particular patient fits into, and then streamline the treatment accordingly. It's so the patient does not get conflicting picture, and everybody does not treat anybody according to their own whim. It is guideline driven. So this is very new technology that we have started doing it. It's called genomic prostate score. But we were doing it in breast cancer already. We have started doing it. There are 2 trials we have opened in collaboration with our colleagues in US and Canada, where this test is being done free of cost. It's currently not covered in the government, but it's coming in next couple of years. We should have it available for many patients. For low-risk cancers, we know that not all low-risk cancers are the same. Some of them come back. So people have started looking at their genomic structure, how their genes are mutated within the prostate cancer biopsy specimen, whether because of their mutations, can they be described not really low risk, but maybe a bit more aggressive. So that genomic score is changing the outlook for certain group of prostate cancer patients. And it's currently available in Regina, but under a couple of trials, but would be offered to wider population of prostate cancer patients in very near future. So if we decide to treat, what should we treat? For instance, if you are localized prostate cancer, should you get radiotherapy? Should you get surgery? And patients always ask me this difficult question: what would you do, doctor? And I get baffled with that. I don't know what I would do if I were in place. Why we give it to the patient? Because the chances of cure or for a localized cancer is very similar in radiotherapy and surgery. It has to be patient driven because the side effects are different. Side effects, for instance, in surgery, it's incontinence. It can cause erectile dysfunction. In radiotherapy, you get erectile dysfunction, but there is very minimal incontinence. Surgery is a couple of days of treatment and then recovery afterwards. Radiotherapy is more prolonged. It sometimes is involved with additional hormonal treatment. So it's not something that I can decide for the patient, or I should not decide. But one thing you have to make sure that when you decide about certain, say I want to go through surgery, then you have to make sure that people who are operating on you, they are qualified. We are very lucky that all urologists are very well qualified. They have done tons of these surgeries. Their infection rate or their control rate is as good as internationally published. Or we can go through currently robotic arm surgery, which is coming to Regina as well, currently available only in Saskatoon, but our patients can go there as well. So all these things are very important for you to consider. And also for radiotherapy, you have to question the doctor. Is your radiotherapy very, very conformal? Are you going to be very precise? How would you increase your precision? What are your rates? Or don't be afraid to ask all these questions and we can absolutely answer them. So then everybody asks, what is a PET scan? That's why I'm not in any order. I'm just exploring everything, but in between I'm giving this information about latest technologies. PET scan it's called PET, which means positron emission tomography. PET scan is where normally a sugar molecule is coated with a radioactive substance that goes wherever the sugar goes. And sugar normally goes where the cells are more rapidly multiplying. For instance, if they have infection, if they have inflammatory disease, or if they have recent trauma, or if they have cancer. The sugar molecule is needed there because cells are rapidly multiplying. So sugar goes more there. Sugar is coated with radioactive substance and it lights up that area, and then it's called standard uptake value. If normal tissues have a standard uptake value of 1, prostate cancer patients sometimes, for instance, would have an uptake of 6 or 7 on the PSMA PET scan, which then lights up and tells us that this is probably cancerous. It is a useful tool to detect early cancer and cancer that is not visible with sometime with normal CT and bone scan. PET scan, mind you, has to be fused with a CT scan because it's not anatomical scan. It just lights up things. Unless we do and fuse a CT scan, we would not know where it's lighting up. Any questions?
Wireless technology.
Is that also known as a PSMA?
So
Scan?
yes, so PET scan can be, we use various radioactive isotopes for different cancers. For prostate cancer, we use a PSMA, which is called prostate specific antigen membrane prostate specific membrane antigen. That's a radioactive isotope that is specifically for prostate cancer. For brain tumor, sometimes we use a carbon-11. And so it's PET scan, but designed for PSA. That's why it's called PSMA PET scan. So this is how it looks like. So on the right side here, you see this black blab. This is a PET scan without fusion yet. So you see this uptake there, but you're not aware of where exactly it is. So you have to fuse it with the CT scan. So when you fuse CT on the left and the PET scan on the right, this is the bottom image that you come up with, that this is within the pelvis, it's within the prostate and bladder, and this is very much so a PET scan which is positive for cancer in the pelvic area.
Doctor, one other question. Would these scans be like a 3D model or just like a plane or a slice?
No, these are 3D. So you get the whole body's images. So 3D is 3-dimensional. 3 dimensions are what? Coronal, sagittal, and axial. Axial is if you look at the image of the body transversely. Sagittal is when you're looking at it from the side, and coronal is from left to right. So these 3 dimensionals are made to make sure that we orientate ourselves very precisely anatomically. Yes, they are 3-dimensional. So this is a gallium PET scan, which is also called gallium-68 PSMA PET scan. It shows that this patient has possible metastasis in the abdomen and in the mediastinum or in the membrane between the lungs, and lymph nodes within the pelvis are very easily lightable, and you can make sure that you cover them either with radiotherapy and treat them as metastatic disease. One of the problems that we are currently facing are there are older guidelines. When they designed treatments, they based on CT and bone scan at a traditional imaging. So those traditional imaging gave us that this patient is localized advanced or metastatic. So the guidelines were based on that. So some of them, CT and bone scan, could have missed the disease far away because the PSMA PET at that time was not available. So, but can we modify our guidelines based on the PSMA PET? That's we currently struggling with in our heads, that all this technology, how we are using it. And people are coming up with thought-provoking theories, what we should do, how should we incorporate them within our guidelines. This is again PET scan, which what they did was, and we are doing it in Canada as well. It's not funded by the government currently, but eventually it will come in fourth, fifth line treatment when all other things we have exhausted and disease is still causing trouble to the patient or multiplying. What we could do is we could treat. So we do a PSMA PET scan, we know where exactly it is, and then inject some radioactive substance in larger quantity so that it, instead of diagnosing, it can treat those areas. So this treatment is called lutetium 117. This is a radioactive isotope that you use for treatment, and recently a large trial has been done worldwide which shows that this is quite well tolerated and effective treatment in certain group of patients. So if you see, for instance, here that it did not respond in all places, but you can see within the mediastinum and the abdomen and beside the liver, there were metastases there, and lower down there, it has almost resolved or made quite a bit of change to the metastases. They are less prominent, and obviously this would also impact patients' quality of life with less pain because of less metastasis. This would not be curable, but certainly would improve quality of life and reduce the other symptoms.
Doctor, we have a question from Myra online.
Yes, Dr. Amjad, thank you very much for that information. It's very interesting. Why don't we have a PSMA PET scan machine in Saskatchewan? I understand that it's really needed, and I know they must cost a lot of money, but still,
So
we used to have one.
yeah, we have a machine. It's PET scan. Normal PET scan can be used for PSMA PET, but we don't have the cyclotron to produce these radioactive isotopes. So they were being imported from other provinces, and we were able to do. For some reason, because of the workload and all that, they stopped doing. And that's where you guys come up. Like I could be crying forever and asking government. Can't put so much pressure on them because they think, he's an employee. What can he do for us? What can he do to us? But if it comes from you guys and say why it's not available, this question is very right. Elections are coming, and this could be, if we together write a letter to the health minister, why Regina people have to go to Saskatoon to get a PSMA or even a normal PET scan, why it's not available in the city? That's a very valid question. We are supposed to be the capital of our province and we don't have that facility. Why we make them go there? So he will say, or the government will say, oh, we are going to get it. It's already authorized, but it will still take 3-4 years. They've been coming up with plans where to put it and a lot of meetings back and forth, but the process is slow. And you could argue that this process has to be. The other day, I tell you, there was a breast cancer meeting, and what they have done is that they're saying the surveillance for breast cancer mammography, initially it was 50 years of age group when you get a baseline mammograph for screening. Now they're changing it to 40. And the minister, I think his name is, our health minister is Hennessy, or I forgot.
Hendley.
Sorry?
Minister Hendley.
Hanley. Exactly. So he was there and he was telling us he's a nice person and he has a listening ear. So he was saying, I was saying that can we cope with extra number of mammographic? They're coming. We don't have biopsy currently available. We are sending patient to Calgary. Why we have changed it? Have we got down the trail all the resources available for these increased number? And he said, yeah, I have talked to the surgeon, I have talked to the oncologist. So I get a little bit upset. I said, okay, good, you have talked to them, but were they in the same room at the same time, or you talked it differently? And they were not. So he was talking, it becomes like a Chinese whisper. You guys could say, why all of you are not in the room? Why it's been going on for 2 years and the PSMA PET scan is not available? You're talking about it to all the people. but all the people are not in the room at the same time. It's being talked to them differently. So everybody comes up with a different notion, different logistics, different problems, and then you go back and go to the original committee and saying, oh, I talked to them, they said this. A month later, they talk to somebody different. They don't talk people on the same. You could say, I'm going to lock you in this room, come up, brainstorm it, and tell me how do we get it swiftly. And that's where the pressure from patients and public should come to them, that it should not be tomorrow, it should not be 2 years. If the money is sanctioned and there is willpower to do it, why it should not be more swiftly? Why can't we cut down the red tape and bureaucracy around it? So very good question. I'm glad you asked.
Thank you. And I would encourage everyone here, when the politicians come knocking at your door, that's a great question to ask them as well. And I also think a letter should come from the board of this community, asking the Minister of Health the same question. You need to get it in writing.
Yes, 100%. There's no
I've heard
substitute.
that. So Myra, we'll bring that to the board.
Thanks.
Good. So this slide talks about what we have talked again. So if you have localized prostate cancer, you can put patient on surveillance, meaning keep a watch on it closely. You can do surgery, you can do radiotherapy. If it's more advanced, you can do radiotherapy and hormonal treatment, and it's advanced, you can hormone treatment, chemotherapy, and targeted therapy, which was not available. We are giving it to all of our patients, and we should be thankful to the government that they have authorized all the latest hormonal treatment and targeted therapy available for Saskatchewan patients. So hats off to them for doing that. So this is one of our association in Canada, and you should also explore this. It's Canadian Urological Association. We meet almost twice a year, and we have collaboration with each other for trials and other stuff, or approving new drugs, newer technology, bringing it quickly for our patients in Canada. And they have established guidelines written there, and for each patient that could also be very useful. This again says the same thing. I can't emphasize how closely the structures are around the prostate. Nerve endings are there, they get damaged and cause trouble after prostatectomy. We do what we call a nerve sparing prostatectomy, but they are so widespread that still there is a chance that we could damage some. So this is radiotherapy technology. Previously, what we were doing, if I can go back, so this on the left side is what we were doing in late 80s and early 90s. This was a conformal treatment. We could only focus radiotherapy by coming in as beams from different angles. Only 4 angles or 2 angles were available because the machine head was huge and we could not tailor the radiotherapy rays into smaller beamlets. So what it would do is that you would enter from the front, sides, and the back, and it would leave more damage to the tissues where you were coming from. Then recently what we started doing now is that because of the technology available, the beam goes around like an arc. So this is an arc that we treat through, and through that arc there are multiple small beamlets which keep on entering from different angles. We avoid certain areas. For instance, if you have a hip prosthesis, we can avoid coming through the hip. We can take other angles and shoot up and give a large dose of radiotherapy to the prostate, which was not possible previously. And we can avoid the areas that we want to avoid to a great deal of degree. So this is what the arc looks like. It shoots beams from, say, this angle, that angle, and the machine has amazing capabilities that it takes images while it's doing it. So it's also shooting the images while it's treating as well. So we can be very precise. This way we can reduce the amount of prostate structures around it into the radiation field. Previously we couldn't do because the machines were not taking images, so we were not sure if we take a very narrow margin we would miss prostate. So this way, if we take images and we are treating to a smaller area, then we can increase the dose and yet be very precise. So that arc denotes that. And I think Dennis, one of our patients who introduced himself, he started his treatment, has 2 treatments now. He's exactly being treated like that. We had to put fiducial markers and some gel between his rectum and prostate, which we were not able to do before, and that also reduces side effects. So this technology is amazing. So this is what it does is, so in the center, this red or orange area is where we want a high large dose. So what we do is we take hundreds of images. We also put gold seeds or fiducial markers there. On the left side you can see that marker, and that tracks the radiotherapy field during our treatment. The machine is able to do that, and we conform to a very, very small area, prostate only, very minimal bladder, very minimal bowel, and every day we are able to treat so precisely. We also, you are aware of that we do prostate brachytherapies, and I think for a smaller center, for a smaller hospital, we should be proud that we have more than almost 1,000 patients almost now. Maybe around 700, if I'm not mistaken, that we have done this procedure, which was, and now other provinces like Manitoba are asking our help. Currently, we can't help them because of our workload. We are able to do this prostate brachytherapy where we put an ultrasound probe in the rectum and image guidance. We can put needles inside the prostate. We can also put fiducial markers there for tracking the radiotherapy field. We can increase the dose to the prostate without damaging much of the tissue outside, and we are certainly curtailed by availability of anesthesia. They can only give us so many dates. We are able to do at least 2 cases a week currently, but if we have more resources, we could do even more. So this is how the hormone treatment works. This is the brain. Brain secretes a stimulus that goes into the testes. Testes secrete the PSA, or sorry, testosterone, which goes into the prostate cancer or the prostate cells where it multiplies. So it's like a feed for this. Some of the testosterone also comes from adrenal gland, which is a small sleeve of tissue on the top of the kidney. So we could block at any stage. We could block, say, at pituitary level by giving these drugs. You might have heard of Zoladex, Lupron, Eligard. These are gonadotropin-releasing hormone substances, and it tricks the pituitary in thinking that there are enough gonadotropin. It switches this channel. Or we can stop this channel and this channel by giving anti-testosterone, or we can do at cellular level, we can stop the testosterone going into the cells. So all these are available currently, and we regularly use them. Unfortunately, they have some side effects which can be quite serious in certain cases, but they are life-saving drugs. So this is what I was telling about, interference of the pituitary hypothalamus level, interfering at the adrenal gland level, or interfering at the testicular level, or the cell receptor at the prostate level. And this guy we have to thank. His name is Charles Huggins. He got a Nobel Peace Prize when he invented or discovered this hormonal treatment, gonadotropin releasing hormones. in 1938. These are the different drugs currently that we give in endocrine therapies, and thanks God, all are available here. And these are second and third generation. Previously, we were using only one. Now we can use combination of 2 or 3 even in combination with radiotherapy. And that's latest, that's only in the last year that trials have shown that people who have very high risk disease, we can do that. You have a question, Maya?
Yes, I do. And thank you again. I understand ADT is very effective. And I've seen, the results from my husband. It's really brought his PSA results down. But I'm just wondering how much is too much? Because what I've been reading, it suggests that ADT is very hard on the organs, particularly the heart. And we've seen an increase in blood pressure. We've seen defib starting to develop. And I'm just wondering, how long can a person be on it and maintain their quality of life?
Yeah, excellent question. I think more than excellent question. So normally for say low risk prostate cancer, we don't give it. For intermediate localized cancer, we only give it for 6 months. People who have high risk prostate cancer, we give it from 9 months to 2 years. And people who have metastatic disease that has spread beyond the prostate into the bones or other organs, unfortunately, we have to give it as long as possible. Yes, it is a very hard drug. It has horrible, sometimes long-term effects, but stopping it prematurely can cause the cancer to grow. So you have to continuously attack it with hormonal treatment, and then even add certain drugs when the cancer figures out how we are blocking their growth by stopping hormones. The cancer is so clever that it starts producing its own testosterone, and that at that time you have to change your strategy and add things on it. But currently gold standard is that hormone treatment is the treatment that has to be added to other treatments. There are unfortunately, no other drugs available that will substitute hormonal treatment, especially in metastatic cancer.
Jean has another
No, I'm fine.
question.
I'm fine.
Okay. And why don't you go ahead?
I don't have a question.
Oh, okay. Thank you very
So-
much.
I have a question, doctor. I often hear from some men in our support group that they also are put on steroids, prednisone particularly, with ADT. I'm wondering if you could talk just briefly about that.
So ADT, yes, some people do. I don't do that. The problem is your androgen is a type of steroids, right? So you're trying to stop it. If you give too much steroids with it, then you are negating some of the effect that it can. It is useful steroids are useful if you, God forbid, you have bony metastasis that's causing a lot of pain. That pain then can be reduced, that inflammation can be reduced with the steroids. And some of the side effects then are accentuated. For instance, weight gain, what you get in, or fluid retention in hormonal treatment that you get. This, if you are on steroids as well, that enhances that. Muscle issues, muscle mass, less of muscle mass, that also steroids can do that. Glucose level that we just heard about, glucose level can increase. So it can be sometimes counterproductive. So I don't like giving hormonal steroids with it, but sometimes you have to do it because of pain issues.
Thank you, doctor.
So this is one of the newest entrance into prostate cancer treatment. It's a radioactive isotope that we attached to PSMA PET scan. It's called lutetium, that can then go into wherever those sclerotic deposits are and treat them. So it's you are diagnosing. Idea is that you diagnose the sclerotic mets through PSMA, and then you add lutetium-117 that will go to that area and give a higher dose of radiation by this radioactive substance and treat locally. This is the patient who had all these black spots are metastatic disease that was present at the time of his PET scan before the treatment, and this is afterwards. His PSA at this time was more than 900, and PSA after the treatment has gone down to 30 and was very useful in reducing his quality of life. Obviously not curable, but still has improved the metastatic disease tremendously. It's currently not available, but if we think not available in Saskatchewan, but if we think that patient is eligible for it and would be helpful, government funding is available to send these patients into BC and Ontario, where the cost is covered, but the travel is not covered. So these are all latest treatments that we can are available to our patients. We start with localized disease with surgery and radiotherapy. They start having biochemical recurrence, which means that the PSA starts elevating, and we know they are metastatic, or we know they are not metastatic being on, so meaning that we can't find any metastatic site. So for this, we have apalutamide, enzalutamide, and darolutamide. If they are metastatic and we know the focus, then we can add docetaxel, abiraterone, and darolutamide in this situation. When they fail this and the disease becomes refractory to these treatments, then we have all these treatments available, which is lutetium we just talked about, PARP inhibitors, which is due to BRCA positivity, chemotherapy, which is docetaxel, and we can reuse some of these drugs that were used previously and has been a while since then. So they work for these patients. So all these drugs that are available, almost we have 7 or 8 lines of treatment that were not available before. So this is the transperineal biopsy. This is the latest innovation in Regina, and currently we have Dr. Wang in Moose Jaw, who specializes in this transperineal biopsy, and we have been referring certain patients to him when we need a very, very precise biopsy based on MRI. So he fuses MRI with his transrectal ultrasound and then do the biopsy. So the probe is inside the prostate, and instead of going through the rectum, which traditionally we have been doing it, we go through the perineum. So then the chances of infection are low, and we can do way more biopsies. And currently we are advocating to train more people into this procedure. So all patients should go through transperineal biopsy, and we should not have any transrectal ultrasound biopsies anymore in the city. And that's another thing that you should advocate, that we should not have any transrectal ultrasound guided biopsy, transrectal biopsies. We should have transperineal biopsies because it's more precise, because you can fuse with MRI, and because it is less infective procedure.
Doctor, I just want to comment on that. I was one of the 3% that had an infection as a result of a transrectal biopsy, and it was very serious. And I understand Dr. Bird, after one whole year at St. Paul's using transperineal biopsies, his infection rate was 0 over 300 cases. So that's really positive to hear that we're moving towards that. Also, too, the transperineal biopsy could actually reach the anterior regions of the prostate, at least that we're showing on a parametric MRI for me that the transrectal biopsy could not normally or easily locate. So I'm really pleased to hear that this is now in Regina.
Yeah, excellent. That's very, very true. And you are so right that biopsy in post-biopsy infections can be serious. And this is another thing that we should write on an agenda and follow up with the politicians, that PSMA PET and transperineal biopsies, availability of the urologist. Then also the third thing we have to advocate for is that robotic surgery in Regina. They have this memorandum of understanding that they are going to purchase it, or orders have been placed, and I think we should advocate that it should be brought sooner and people should be trained on it.
Yeah.
One more question, Doctor.
Yeah.
Oh, you're good. Can you also place the fiducial markers that using that process as well?
Yes, transperineal, yes. So was that Dennis?
No, it wasn't.
Beside Dennis.
Right beside Dennis.
Okay, so yeah, we had fiducial. If I'm not giving too much information, we placed markers for Dennis through transperineally a couple of weeks ago.
Thank you, Doctor.
So this is another thing that you will be delighted. What we have done now is that I have been certified now to place a gel between prostate and rectum. So normally you can see this is the rectum there on the left side. This is the prostate and that's the tumor. When we give radiotherapy, we have to, some part of the rectum gets burned or scarred and causes in some patients, especially who have diverticulitis, ulcerative colitis, or Crohn's disease, it can be a long-term issue. Now we can place an ultrasound guided gel between the rectum and the prostate, so we create a space that reduces the dose going into the bowel and reduces the long-term side effects. And we have so far done, I think, not mistaken, 12 or 15 patients, and we have now funding for as many patients as we want to do it.
Hi, Dr. Amjad, this is Lori. I just
Hi.
have a question for you. A post-prostatectomy and an occurrence of the cancer in the pelvic floor bed. Can we use a gel, a similar system? No, there's
No.
nothing there to protect the rectum.
No, very good question.
No?
This is more for intact prostate. The reason is, first of all, we are not sure where exactly it recurs, and we sometimes gel can obstruct the radiotherapy going to the right place, because it can obscure the disease itself, and it's not recommended in prostatectomy patients currently.
Thank you, Doctor.
So this is again, we put patients in different categories to the same thing that we were talking about. So this is my talk. So I'll summarize what newer drugs or new technology we have. First, I'm very pleased as we talked about transperineal biopsies. Then we talked about the gel that we can place. Then we talked about I can do my own fiducial markers in the department, so we are not limited by the interventional radiologist there. We can do it all ourselves. We can enhance the dose for radiotherapy. We have newer drugs come up that can enhance the cure rate or control rate of the prostate cancer. We also are going through the PSA PET scan being installed here, and we are also in agreement that the robotic surgery will be brought to Regina not in distant future. Thank you very much. And I'm open to any further questions or discussions.
Dr. Amjad, I just want to, on behalf of everybody in the room at the Cancer Institute, I just want to thank you for your presentation. On behalf of everybody online, I just want to thank you for your time. I do know we have some time for some questions.